Good afternoon, everyone. Welcome to the last session of AIOC 2023. This is we have planned it differently. Our group has been doing instruction courses regularly for the past 5, 6 all-day conferences. We have each time the theme has been different, and this time what we had thought was there are situations where you are in a doubt whether to do. See, there are two options were there. Which one to choose? Always we are in doubt. So that is in some cases there are more than three options as solutions. These I have a wonderful panel with me. Dr. Prabhu Shankar. Dr. Prabhu Shankar is a very acclaimed veterinary surgeon, and he does wonderful anti-segment surgeries also from Shankar Eye Hospital, Coimbatore. And Dr. Umesh heads the Shankar Eye Hospital in Bangalore. Is a phaco-refractive surgeon, and so he like many times whenever I have doubts and I want to know which way to go forward in particular situations, he is one of the persons whom I go to. Then we have Dr. Vanati, the newly elected editor of Indian Journal of Ophthalmology, and professor at RP Center, AIMS, and then we have Kaushik Murali, who effectively heads the entire Shankar Eye Hospital operations across India. He's the president of Shankar Eye Hospitals. And Samarish was supposed to join us, but he had to go back. Some family problems there, so he had to leave early today. And Gopal is one of the best veterinary surgeons in India. And I'll just start with my presentation on if when a patient is on table and he becomes uncooperative, what should we do? Which podium? Both.
So, Dr. SREENI will be talking on cataract surgery and topical anesthesia, especially when it turns stormy. What next?
Thank you, Umesh. And once again, good afternoon, everyone. See, but mostly we go for topical anesthesia cataract surgeries these days, and either under topical anesthesia or even under block, there are situations where the patient turns uncooperative. Under topical anesthesia, there is no reason. The patient is just uncooperative. The patient is not able to look directly up and keeps on moving. So that is one of the causes why you get an uncooperative patient on table. And you feel, let's say the patient becomes uncooperative. One of the reasons, he might not be, he might be actually a cooperative patient, when he might turn uncooperative because our topical medications has not given enough analgesia for him, and you touch his conjunctiva or wherever, he gets a pain and he keeps moving. So that is one. The other one, the most difficult to manage, is claustrophobia. You might have had at least one patient in your career who had claustrophobia and you had to struggle with that. The other one is patients, everything goes up fine. The patient starts coughing because of breathlessness. I'll come to all these. So let's first see this patient. The patient obviously was taken up for cataract surgery under topical anesthesia. See, from the beginning, the patient was not really cooperative at all. But most of the times, I'm able to get through with these patients. After some time, they start cooperating. So this patient, I thought, okay, I'll be able to do it. And so the section side port both were made, and so because you're holding the globe at 2 points, the globe was stable. But then again, he started rolling his eyes about. So when I because when I was sure that it's going to go in many directions, and I'm going to lose the globe. So I decided to stay in the capsule, and so till then, okay, like he was okay there. Then I just trying to remove that trypan blue and all. Then again, he's absolutely not cooperating because for me to do a proper access, the eyeball has to be stable. Otherwise, definitely it's going to go to the periphery. Then so this is a situation, and see there are two options here for me. Uh, so one is to give a block itself, peribaba block. But peribaba block here is going to push the globe. You need at least 5 ml of anesthetic there, and effectively open globe. Then see the better choice is not that I feel like it is a subtenance anesthesia, and so you make a nick in the infratemporal quadrant in the conjunctiva, and you go in with that special needle for subtenance anesthesia, go hugging the globe, go till you meet the hub there, then you inject. See, the two movements have to be smooth here. The movement of the cannula in and the injection also should be smooth. Then only you're sure that you're in the right plane. So the analgesia happens almost immediately. But the echinacea, for the total echinacea to take over, it might take quite a at least 3, 4, 5 minutes. Literature says 10 minutes. But in within a minute, the movement lessens, and you'll be able to complete the cataract surgery. And so the only issue here is that you might have some subconjunctival hemorrhage here, but it goes off in 1, 2 days when your surgery goes off very safely. So this Tenon's capsule actually is anteriorly attached to the conjunctiva and fuses at the level of the lemma. I'll tell you why I mentioned that. And this is from the literature. They say the nick in the conjunctiva has to be 5 to 10 millimeter in the infranasal limber and can be as far inferior in the fornix depending on the patient anatomy. But I've found that, see that I just repeat the procedure. I've found that the more posterior you go, the lesser chance that you get the correct plane. So I don't go really posterior for the neck. It's about 5 millimeter or so from the limbus, and it's like a hugging move there. On the cannula hugs the sclera and goes behind, and the amount of the lignocaine that is used, I use only 2 ml. They say 5 ml is good for echinacea, but 2 ml I feel it's good enough. I don't want see when the globe is open, I don't want more volume of fluid there pushing the globe. So these are the different cannulas. You can see different gauges are there, different points where the openings are there on the cannula through which the lignocaine comes out. Whichever it is, it works. 1 port, 2 port, 3 port. See, even 1 port it diffuses, 2 port it diffuses. It doesn't matter. I'm just a bit worried about the thinner ones, 23 G ones. It might not perforate the globe, but it looks like a normal needle. So I go for a 19G or maximum 21G cannula for this. No financial interest at all. This is from Episamia, and this is from Epsilon. And so just this is it. This is the point where I nick the conjunctiva, and you can see that it's going in smoothly. And if it needs some resistance, it's manipulated around, and when you start injecting also, if you get some resistance, just manipulate it. And if it is not going in, then come out, repeat it. you make a nick somewhere else and do the procedures. So this is and complications. I mean, effectively, no complications are possible. The possible complications are neuropuncture, brain stem anesthesia, globe puncture, intravascular injection. With this blunt tip, it is not possible. The only thing is might have some bleeding wherever you have nicked the conjunctiva. Coming to claustrophobia, these are the most difficult patients. See, when it happened to me first, I thought, I'm good enough. See, I take only 5 minutes or even less for phaco, and I'll be able to just talk to the patient and do it. No, I've burned my finger many times. If the patient say when you put the drape, he or she says no, then I just postpone the patient. See, like I mean, so many cases to be done in a day. You're not going to talk to each patient with pre-anesthetic checkup and everything that you do for head and neck surgeries and all that. We don't usually do that, right? So on table, and the patient is also not aware. They might have never slept with the bed sheet on their face. So this is the first time this is happening, and it happens on table. So you can't blame them. So if that happens, I just postpone the case. I don't do that case. I don't attempt it. I might just try it out in the preparation room. I tell the nurses to just put it again. But nearly 100% of the cases, they don't agree. Then I talk to my anesthetist and counsel the patient. And so many times, these are the tools to detect and effectively manage claustrophobia. One, see this on hindsight, like you know that he's claustrophobia, you find out, okay, a history of claustrophobia, counseling with the attention, anxiety provoking factors, trial run. You people say you do it in the OPD, but I do it in the let them have a feel of the OT. I do it in the preparation room and give them a choice of general anesthesia or whatever anesthesia other than block and topical. This is very important. See, those who are scared, they want to hold somebody's hand. They tell, sister, you be there, hold my hand. So let somebody be there. Music, they say, I don't have a music system, and you have mobile, but I've never tried that. So it's hand holding that, and obviously, like try not to have any complications. Everyone has a particular surgical time, and so reduce the surgical time to a minimum. Constantly talk to the patient. Normally, I don't. I just do it, and at the end, I say, everything is fine. But in these cases, I just keep talking to them. And another thing, like there's this opaque drape. It doesn't give them the view of what is there outside. So the other eye also give that clear drape so that they can see, tent up the drape. So these are the things that we do, and this is very important. If the patient coughs midway through the surgery, you should always consider pulmonary edema. Stop right there. Just ask the patient if he or she is feeling uncomfortable. It is pulmonary edema. You'll have to intervene wherever you are. You have done the chop and it is there. It doesn't matter. Stop. Take the patient. Give the patient to the anesthetist. F-colon, whatever, Lasix, everything given. Save the patient's life, and then take up the patient for the surgery later. They'll be actually very thankful to us. They won't blame us for doing half the surgery. So this is basically on what I could think about the sort of uncooperative patients that I've had in my OT. This is it. Umesh.
Yeah, thank you, Srini. That was very comprehensively spoken. I think the take-home message here would be that the best way of avoiding these would be appropriate preoperative identification of these patients, Uncooperative topical, you can identify them when you're doing your slit lamp examination, when you're doing your A scans, when you're doing your indirect ophthalmology, you can definitely know. And by giving proper counseling, most of them will convert into topical, or if you know well in advance, you can always shift them to blocks. And regarding claustrophobia, I think we also see a lot of such cases. One prevention thing that we are doing is, for such patients who have claustrophobia, we ask them to sleep in the block room and with the drape on, and ask them to sleep for 5 minutes without any procedure. So most of them by that time get used to it. And in severe cases, we have done anesthetist around, obviously, with midazolam, and that definitely helps because it's a 10-15 minute surgery. Midazolam definitely helps. Please talk to your anesthetist, they'll be able to do a good job. Thank you,
I want
Srini.
just a few points to add on to that is very similar to how Srini did give his subtenons. You could also make a small nick after anesthetizing the cul-de-sac and in the inferior fornix, and just pass your IV cannula here, what you put on, and then you have at the end, and you can keep injecting and reinforcing. It does go into your subtenon space, and there you do have the freedom of giving in more amount of anesthetic if you need to reinforce subsequently. That's one point. You also have Thornton fixation rings of different sizes with which you can just hold the globe at the limbus here, and that also helps you to stabilize the globe in these patients. One. And again, claustrophobic patients, we do have that particular rod which is attached to our table, and that lifts your surgical drape a little higher and gives space
Yeah,
and
tenting up.
allows them, yeah,
Yeah. But even that
even with that, yes, I do agree, they do need a lot of reinforcing in terms of
it's
emotional
that
support.
feel of
Yeah.
something blocking their
Yes.
view and everything. So
Yes.
next we have uh, probably one of the most versatile surgeons, eye surgeons in India, who's really good with VR surgery, and absolutely his anterior segment surgery is an art. So I mean, for this session, I've asked him to concentrate on the anterior segment part of it. He'll be talking on two topics. The intraoperative rock hard eye. I mean, the eye becomes rock hard during surgery. There can be a few reasons for that. And when the nucleus doesn't rotate, what should you go for? Dr. Prabhu.
Thanks, Srini. So I'll just go into the first video. What happens now after the phaco surgery? And once you decide after the cortical wash, you can see the chamber shallowing up and basically pushing up, cornea bulging up and eye. So what happens is now after the cortical wash, you can see, all the viscoelectric is coming out. You try to open the main section, the iris is coming out. So you know that something is wrong in the globe. You shouldn't attempt further. So every time I just try to push the iris, it's just coming out through the section. So I'm just trying to repose it from the side, and some temporal cortex is already left because the PC was bulging and I didn't do an AC wash. So in this scenario, what I do is I just aim, the glow is pretty good. So that's important feature, red glow is good. So 3 millimeters from behind the limbus, I either go with a 24 or 26 gauge needle. I just go right behind the posterior capsule. What happens is the fluid gets locked during phaco, the fluid gets locked in the burger space. So between the anterior hyaloid and the posterior capsule, the fluid gets locked. So PC tends to bulge up. So now what I'm doing is I'm just gently going out. You can see the needle under the posterior capsule. So I gently aspirate. You can see the eye collapsing slowly. So now you can see the folds in the PC now. That means the PC is going back, and even the cornea, there's some quite few folds. So that shows that some hypertony is there. So now I go inside, put in the visco. So now we have quite a deep anterior chamber. So and now we can proceed with your IOL implantation. So now it's comfortable. So whenever the iris is prolapsing post-phaco, post-cortical wash, your iris is prolapsing and a PC is bulging, never attempt to put a IOL because 100% you're going to end up with a PC rupture and anterior vitrectomy. So in this case, went on smoothly because the chamber became very deep and the posterior capsule also went behind. Next.
Prabhu, see, there are a few more. This is done on
Yeah,
interoperator.
two more videos.
Okay.
Yeah, this is another one. This is another patient with again a positive pressure post phaco. So only thing here we have to just see, look at that episcleral vessels. They're all dilated. So this is one clue. I'll tell you what happened. So and now I decided, okay, I'll again attempt with 25 gauge needle. So usually you need to go around. You should also try with the 26 gauge needle also can be right, but the 24 gauge needle is quite easy to aspirate that liquefied fluid. So what happens is I just go behind and try to aspirate, and in this condition nothing happens actually. Neither the fluid gets tapped from the anterior hyaloid, the piece is still bulging, there's no change, and even after this maneuver, so once the eye is still pretty hard and nothing is happening. The small hemorrhage there near that area where. So once the PC was bulging, so you can see the iris that's stuck to the wound there. So there's no hypertonia at all there. This positive pressure is still there. In this case, I decided not to proceed further. So what I did is after the patient just closed up the case and asked one more of my VR consultant to have a look. And what they said is patient had a suprachoroidal, aborted suprachoroidal. There's one danger we should all keep in mind. So once you attempt tap from the anterior hyaloid and nothing's happening, make sure you don't proceed because there's always a chance, in spite of a good red glow, patient had aborted suprachoroidal hemorrhage. So there's another patient during cortical wash, you can see the PC bulging up and very difficult. In this case, you'll have to be very careful because the minute or the smallest mistake you do and once the PC gets ruptured, then you'll have to again do extensive anterior vitrectomy, cortical cleanup and everything. And here somehow managed it to do gently. And once you finish the eye, you can see the iris getting stuck there. So again, in this case, is another video where I tapped it from the temporal quadrant. So another thing, I think what Umesh was saying is they just put a trocar candle, 23 gauge or 25 gauge trocar candle, 3 mm behind the limbus, and that just keep it open, that fluid gets tapped off. So instead of putting the needle, only thing we should have that instrument set ready.
The advantage of putting just a one trocar cannula would be that you are not aspirating.
Yeah.
See, if you look at the pathophysiology here, it is the high fluidics or the saline that goes behind into the burger space, and you just need to remove that fluid. That's all. So when you put a trocar cannula and just leave it, there is no aspiration happening. Probably the fluid, once it comes out, then you can go ahead.
Only thing is you should have to use the non-valve cannulas.
Yeah.
If you use the valve cannulas, then nothing's going to happen. You have the non-valve
See,
cannula.
if you have actually tried to attempt vitreous tap in endophthalmitis with a 26G needle, nothing comes out.
Yeah, yeah.
So the traction, so if it is a 30G needle, it'll be much better. But the best to use, I mean, if you have a small gauge vitrectomy cutter, you can just go with it and aspirate there. But second video, so that's what I wanted to discuss in the beginning. Say before you actually aspirate it, you have to make sure. See, I'm not really worried about 26G needle or 30G needle causing traction and causing brakes. No, probably it won't happen. But the thing is that this whatever is happening could be because of an expulsive end
Yeah,
process.
that's what.
See,
Yeah.
so before putting the needle in, I would always ask. See, I mean, we have a long OT, and not so. Ask our retina colleague to see if it is that, then
Yeah.
then nothing. Leave it there and plan everything. So if it is not there, give IV mannitol. See, before trying, because it has happened to me at least 7-8 times. So only after seeing your thing, I've attempted it
Only thing
twice.
is, no,
Yeah,
in this special condition,
yeah.
IV mannitol doesn't work.
No.
The fluid gets locked there.
No.
IV mannitol, you shouldn't actually want
It works. See, what mannitol does, it causes shrinkage of at least a little bit.
yeah.
Shrinkage of the vitreous. That's what. See, any shallow anterior chamber surgery, a crowded anterior chamber, what is advised is 100 ml or 200 ml mannitol half an hour to 1 hour before the surgery, because that helps. Here also it is going to help, and it might not be that easy. So in one case, I in fact had postponed the case for about 2 weeks, and I took it. So if you are actually sure that there is no expulsive, yes,
Yeah,
you can do all these procedures.
That's why I showed both the videos.
Yeah. That's it. Gopal, your opinion on in this aspirating, because the aspiration is happening. This is a fluid that goes through the zonules into the Berger space, which is a potential space between the anterior haloid phase and the posterior capsule. So you, whatever comes out easily is just the fluid. It's not the vitreous. You're not going to keep on trying to aspirate and all. It just comes out easily. So your comment on this thing.
What I would like to say is, if it is a young patient, you put a needle into the vitreous, it will induce a PVD. You don't have to aspirate. If it is an older patient, 60 plus, already PVD is there, then even if you aspirate some fluid, nothing is going to happen. So in a young patient, we need to be very careful. A young patient, or the patient in whom PVD is not yet there, you put in a needle, definitely PVD will be induced. There are studies that an uncomplicated phacoemulsification in a patient who did not have a PVD induces PVD in about 50% of people in the next 3 months. So induction of an unnatural PVD definitely brings in tears in the periphery. So I think the world is going towards a lower age for cataract surgery. So I don't think we should generalize like that. Your theory is very well taken. It's a fluid which you are aspirating. But in a younger patient, be careful. That's all.
Yeah, this is a process for which Boris Maligan won the best video award. See how this happens. It's called
Fluid
acute
misdirection. Fluid
intraoperative
misdirection.
rock hard eye syndrome, AIRES. So he showed the video on how this happens. See, like during cataract surgery itself, you might sometimes post-operative, you might sometimes see some cortical particle sort of things floating around in the anterior vitreous. You don't understand why this has happened. See, these are things that have gone through the zonules into the anterior vitreous area. So he actually demonstrate how it happens, and he got the best video award. And now Prabhu, you have anything? Oh, okay. And the next presentation by Dr. Prabhu is on how to manage. See, if you have a non-rotating nucleus, what next? Yeah.
Can I have a short comment, sir?
Yeah, please.
Yeah.
Kaushik, please.
So in acute intraoperative hard eye, I think one should also ask, I'm Dr. Swati Agrawal from Kolkata. So I think one should also ask the patient to, loosen the speculum, ask the patient to breathe in through the mouth, and then do a sterile IO first, which is a must, I guess, before inducing further hypertony. And if it doesn't work, we can shift the patient to the ward, wait for the mannitol to take its full effect, and a vitreous tap can also be done, or alternatively a pars plana aspiration with a vitreous. We can
Small gauge vitreous.
yeah, with the buds or any spatula, we can tap at the globe and see whether there's no hypotony. So hypotony should never be induced, and thereafter we can proceed. So I had this case where the cornea turned white and waited for 1.5 hours, 90 minutes, and then took up the case. Again, I displaced the viscoelastics from under the iris from the opposite port. So, sometimes viscoelastics can get trapped, and that again further induces. So, some prophylactic measures needs to be taken. Thank you, sir.
Thank you, thank you. Prabhu.
It's a small pupil with brown cataract, so always safer to put the retractors first, and you can always stain whenever you want. Restain the make sure, especially in brown cataracts, you get good capsular access, because especially hard cataracts, if the access goes wrong, your surgery is going wrong. So very hard cataract, I have not done a hydrodissection yet because there's hardly any space there. So once going through a vertical chop or 2 millimeters, initially once you get the first chop in, and you get a small chop, it's very difficult to rotate the nucleus because there are a lot of capsular cortical adhesions there, nucleus never rotates. See, when I'm trying to manipulate, nothing happens. So always in a brown cataract, if you're not able to rotate anything, make sure the first small triangular piece of nucleus is removed from one edge, or a central core is removed. Once the space is created, the fluid starts moving around inside the bag, and then next step, the nucleus nicely rotates. So only thing but only thing is when you do, if you see, if your hydro has gone through and then your nucleus not rotating, then always keep in mind posterior capsular dehiscence. If your hydro is through, if you're not done a hydro, then you are pretty sure that the PC is not opened up, then you can do all the maneuvers. Should always be careful when non-rotating nucleus is there during your procedure. Always think of posterior capsular rent, and make sure that you don't drop the nucleus during your procedure. So after that, only thing is, see, even in spite of nucleus rotating, we're not able to get at it at all. So sometimes you have to bring that one of the edges out, hold it, and get the triangular bit of nucleus out of the bag and create a maneuver. So then you can always use a second instrument and get the nucleus out. Srini, any point on brown cataract? Srini, anything in brown?
See, on the first point, why didn't you do hydro in the first place?
I don't do actually in a very hard brown cataract because hardly any space is there, no? And you get a hydro through a first run, nothing happens actually. So especially in brown grade 4 cataracts, I don't do hydro. You get the trench in, get the first chop, get a triangular piece out, then the nucleus starts moving. Because I'm sure that I've not opened the PC.
Yeah. Especially in women, the PC is so thin. Especially in women, the PC is so thin that you do the hydro like the way that you do for the other cases where you want to see the fluid wave and all. If you do that, you might find the nucleus in the vitreous, even if there is no posterior polar cataract. Any comments?
I think without doing hydro also you can loosen up the nucleus, and that is a simple procedure. We can just rotate, half rotate or quarter rotate. That itself will take care of most of the thing. Probably the non-rotation in a hard cataract, most of us will follow. We'll see at some point of time, and when you see that, some of these tips and tricks will always work. I think the removal of 1/4, what it essentially does is it debulks the whole bag. Then you have enough space to maneuver, and that helps you to further rotate more with more peace, because you're always concerned that when you do excessive rotation you can drag the bag or the lenser. So once one piece is out, when you have space, maneuverability become easy.
So the rotation is attempted only after removing a pie, right?
First stretch, yeah. The chop.
Okay.
This is another video. You see already the posterior capsule is opened up completely. So in this case, you cannot do a hydro, cannot do rotate the nucleus. So what you have to do, just slowly debulk the nucleus from all the quadrants, and finally from one pole you have to lift up and slowly, since it's a soft cataract, it's relatively easy. And maneuver should be very gentle. You can see the posterior capsule opened up behind. And since it's a soft cataracts, you can just gently aspirate it. And make sure before the last quadrant is aspirated, you come out, inject visco, deepen the chamber, and then remove the last fragment, because the PC just bulges up, and again the vitreous also will come out. So in this position, I'm just holding on now. And I just put in the visco through the side port. So stabilize the chamber, stabilize the back. You can see the posterior capsule completely opened up there. Then aspirate the last fragment. So hardly any movement in the anterior chamber, and the nucleus with the cortical matter comes out. Now everything is stable now. The only thing is these conditions, you'll always make sure you never decompress the back or the anterior chamber, because the vitreous can come out. Now I'm placing the IOL into the bag now. So the posterior capsule is already opened up. So this same non-hydro technique is always safer for any type of posterior polar cataracts. So once, or the other option is to do hydro delineation. In this case, you cannot do it because the capsule is already opened. So any posterior polar cataract, never do hydro dissection. Either delineate or go for a no hydro phaco. That's the safest procedure. SREENI, posterior polar.
Yeah, I feel, see, nowadays I'm doing no hydro phaco for all posterior polar cataracts, all, even the softest, because see, even when you do a hydro delineation, there can be a breakthrough, and it can cause. See, what is happening? Like, the intracapsular pressure increases, and see this absolutely brilliant surgery here. The PC is already opened. See, there are when you see some word like this, see the two types that you see of a posterior polar cataract. One is, if you see that whorl there, uh, uh, you get, after, at the end of phaco, you see that pseudo hole there in the posterior capsule. See, those cases are absolutely fine. Like, if you're careful and you're not, again, keeping on polishing or not, they'll be good. But it's those posterior polar cataracts where you have uh, sort of deposits at the center of the posterior capsule, and you feel, okay, everything is fine, everything went off fine, and you're going to polish that part with whatever you're doing. The PC is going to open up
That's
there.
what in posterior polar cataracts, you should expect the PC rent anytime.
Anytime, even and
IOL aspirate,
after
cortical
IOL
aspiration,
implantation
IOL
also.
implantation. Even I've seen the PC opening up when I'm closing up.
Yes. So
the
this
smallest
happens.
of mistake you make, your PC is going to open.
Exactly. So
never do PC polishing.
like, all those things are there. You need hydro procedures for phacoemulsification. You don't need hydro procedures for phacoemulsification. So doing a wonderful cortical cleaving hydro reduces the amount of cortex that you have to aspirate. But you try phacoemulsification without hydro, it works. So in these cases of posterior polar cataract, I don't do any hydro procedure at all. They say, okay, why don't you do visco dissect the anterior capsule from the lens matter? It doesn't matter. What matters is how you take care of the posterior part. So it rotates. You initiate the phaco. If it is NS3, 4 and all, then do the dissection. Once you do the division, chop and divide. Once you do the division, all these additions break up, and you can easily rotate. Very soft ones are the ones that you might not be able to rotate many times, but you will be able to aspirate. So that is what I go for in posterior polar cataract these days. And
this is the last video.
I'll send my the first paper for Dr. Vanati. It's already ready. So I'll send it.
Yeah, this is another one with subluxated lens. I'm putting in a CTR. So PXF is there, subluxated lens. Once the CTR is in, If you can see the temporal zone, you can always see the edge of the lens there. So in this case, so then slowly I start the phaco now. So since the entire bag is moving, so after my first trench, I'm not able to rotate the nucleus at all. You can see the chamber depending, the lens going much behind. I get the chop done and hardly any movement is there. So again, I try to create that triangular bit of nucleus out and get the first small bit out to create space, but hardly the nucleus is moving. You can see, the lens jumping inside because of the subluxation. Some of that nasal quadrant of the nucleus I'm able to remove, but the temporal part gets stuck there. So there's hardly any movement of the nucleus inside the bag. So subluxated lens is always better to put the CTR right in the beginning of the surgery. So only thing, hydro will be very difficult. Hydro dissection will not go through. But anyway, the chamber will be stable and the nucleus will be stable. So now again, I'm trying to put 2 dialers and trying to rotate. Nothing's happening there because the temporal zonules are very weak. There's hardly any movement there. Some minimal movement is there. Then I just see nothing's happening. So somehow I just try to get half of the nucleus out. Now you can see the bag moving a lot inside the eye now. So I'm just trying to get a hold of the nucleus in some edge, at least try to debulk it as far as possible. So only thing is, all these surgeries, in the beginning, if you know it's already subluxated, better to block these patients because you don't know how long this procedure is going to prolong. All subluxated and nucleuses. You can see the lens wobbling inside. There's too much of movement. So this is the time I decide, okay, put in the capsular hooks.
Yeah, this is what I wanted to ask.
Put in the capsular hooks for the last quadrant. I do it. So put 2 capsular iris hooks. I hook the capsule instead of the iris, and now things stabilize now. So whenever you have a zonular dialysis, always put a capsular hook in that particular quadrant, and things are very stable now. See, I'm ridiculous rotating. The surgery goes very smoothly now. The pupil has come down a bit from that full dilated position to around 4 to 5 millimeters. But since things are so stable now, since the capsules are hooked up, there's hardly any movement. I'm able to comfortably complete the phaco. And once you put in your lens, you can always remove all those retractors, and things are very stable now.
You put an iris hook or a capsule hook?
Yeah. So I've hooked the capsule actually.
Yeah.
So things are very stable now.
It's an iris hook like once.
Same iris hook, I just hook the capsule.
Yeah.
Not the capsular hooks. The same iris hooks.
The advantage with capsular hooks is it protects the equator. But now that the CTR is in place, it's okay. Yeah. Iris is okay because if you do it with just the iris hooks,
we don't know all these grossly subluxated lenses how long they're going to stay. I've seen my own patients after 5 years, 6 years coming down with dislocation.
Yeah, that depends on the pathology that has caused the thing. If it is a traumatic subluxation, it doesn't progress. If it is something like pseudoexfoliation, you will find the whole capsule IOL CTR complex in the vitreous after some time. It'll be there. So
that is why most of us now prefer putting the 3-piece sensor, because when it goes, we do internal fixation and can do a MNS technique, so that no need to remove it. So that is one technique that we are doing, where you know that there is subluxation in future, you anticipate it is going to drop or whatever, you put a sensor 3-piece.
No, the technique advice is put it in the sulcus and capture.
No, even otherwise, once the zonules are there, progressive zonular weakness.
It gets stuck to the. It's there in the sulcus. For a little bit of support and for centration, you capture it in the.
Thanks,
so, thank you, Prabhu. Wonderful videos. Thank you. So now we have Dr. Umesh Vai from Shankaraya Hospital, Bangalore. He'll be first speaking on what should you do if you get repeated iris catch by the phaco tip, and then he'll speak on IOL implantation mistakes. So,
Yes, thank you, SREENI. Thank you. This is the last part of the conference, and thank you for hosting such a wonderful conference. And I'm sure all of you must have faced this, and especially those in beginners and those who have used the previous Indian IOLs, where there were some issues. Most of the manufacturers had issues with the loading cartridges, and that is where most of us loading and pushing, we used to have a lot of IOL implanted mishaps. And now, after going through so many things, now we know how to explant them also. So this is not the regular Indian ones. Mostly we see that, but this is the Johnson and Johnson one. You can see that the haptic is gone. There are quite a few reports which say that if the haptic, just the haptic, if it unfolds, you can always go ahead and put. And I think there was one study in hydrophilic lenses where you put it in the with one haptic gone, you will have, there won't be any vision loss. But since now we feel that it should be fully stretched and the capsule has to, you have to put a single monofocal piece without any cut. So now we all plan to remove explant the lens, and this is the Johnson and Johnson Technis 1 lens. To add Technis 1 lens, higher RI and thicker lenses when compared to the Alcon and other series. So you will have some issues. So these are the tips that we will be discussing today. Most of us now talk about removing the lens through the same incisions only. We see quite a few techniques of cutting the IOLs. There is a partial transaction using the hinge technique. There is a full transaction. I think these are the two things that most of us see. The others are so quite difficult. So we just go through the first two things. So we'll be discussing about the partial transaction and the full transaction. What are the instruments that we need to use to cut? We need to use the micro forceps. There are special IOL cutting forceps now. And previously we used to order from all the MNCs, which are very expensive. Now you get with our local vendors only. Only thing is, you make sure that the IOL scissors, cutting scissors are like this. They are like the crocodile teeth, and the micro forceps. Sometimes we do manage with the forceps, the 23 gauge regular forceps, but the IOL holding forceps must be having these additional steps. So that will help you to hold on to because that is very important. That is where most of the mishaps occur. So these instrumentation is very important for us, and we compromise on this. That is when we end up in problems. So we will be going with the complete cut. So you hold through the side port, of course, under full viscot control, and do a through and through cut of the IOL. That is the full transaction. You can keep on cutting. It's very, it looks simpler if you have a very good instrument, cutting instruments. Most of the time we struggle only when the cutting instrument is not good. So make sure that you have, once you do that, you can remove, because if you cut correctly, you're doing around you have a 2.8, so 6 mm optic. If you cut into half, it will be 3 mm. So slightly adjust the incision size, and then you can remove both of them easily. So probably 2.8 to 3 millimeters, if you just squeeze out, you can get the hydrophobic lenses out. And this is how you can remove. Whereas if you have to do a partial transaction essentially means go up to the center and beyond the center up to 3/4, and then try to rotate it and in a hinged process. As a hinge, you just remove it by rotating, remove it, and that is what is called the partial transaction. So you have a complete transaction, cut it into two halves, slightly elongate the incision to 3 mm, and get both pieces out. And this is the partial transaction. If you see, we cut it up to the edge there, and then hold one part, the haptic, get the haptic out, and slightly use it as a hinge and try to get it out. The central cut portion will act as a hinge. So you hold. Yeah, you rotate there. That acts as a hinge. Keep rotating, and once that is done, you are done with it. For sometimes when we don't have the appropriate instrumentations, or we are not equipped with the, or not willing to do the cut process because you are not happy, I also recommend that you do go and just shift it to a simple manual SICS, and just it's very simple. Instead of going and harming the IOL inside, you can just go there and remove it through the 6 mm. This is just for demonstration purpose. This is not a cut haptic actually. So you just make a SICS there. This I removed it for a refractive surface of -6. So you don't have the instrumentation, you just can make, this was essentially a phaco. You can see the phaco section here, then made a superior section, and then remove the through the manual small incision. One technique that has been described, which I have definitely not tried, this is in literature, is that you can get it through a 2 mm, 2.2 millimeter incision also. The technique is that you cut it into a triangle like this, the way they have cut it. It looks very simple as it's shown in the diagram. It is not, believe me, it is not that easy. Once you do that, essentially the 6 mm zone is divided into 2.6 and 2.68 millimeters. So that means each part is around 2 less than 2.8 millimeters. So you can just remove it squeezing through the 2.2 millimeters. That is what they have been described. But this is just for theoretical purpose. But I have never tried these things. So to conclude, there are many techniques that are available that shows explantation. But the simple and effective ones would be the complete transaction and the partial transaction. And if it is a complete transaction, you need two good instruments, the holding instrument and the cutting instrument. They are very important for you to get a first cut up perfectly. Srini, any questions?
So would you, what is your preference? Like, if you can cut, why don't you cut it full? Why do you go for?
Yeah, I do a fully.
Yeah.
Simple technique would be partial and complete. Partial also it is effective. You can do.
No, why? See, the risk here is the IOL touch onto the endothelium. The risk is much lesser if it is.
Yeah, I will tell you why the partial section was. People, some of them wanted this partial section. See what happens. There are many mishaps that occur when you're going and cutting. You're going towards the opposite side. There is chance of injury to the iris when you do a complete transaction, and because at the periphery, injury to the iris.
You rotate it and complete.
Rotating and complete. Yeah. So these are all multiple steps. Each has its own advantages.
And would you recommend putting viscode or something to protect the endothelium while the IOL is being
yes,
taken out?
you have to, but once a couple of them you do, you will realize that it's only a one-step process cutting.
Yeah.
Once the cutting is done, the removal is as simple as putting.
So most of these lenses now, foldable lenses, hydrophilic or hydrophobic, excellent extension. In case section to around 4 to 4.5, folded with nice forces, pull it out most of the items.
Yeah, that's the pulley technique. I didn't have the video. I wanted to get that's a pulley that works beautifully in a 3 mm section only. That works for hydrophilic lens very well.
Hydrophilic, yeah.
Hydrophilic lens, very tough for hydrophobic. You will
it's
end up injuring the iris and all those things.
Yeah.
But I think a complete cut is very simple, provided you have a good iris cutting lens. Lens cutting.
No, if somebody doesn't have, it doesn't cost much.
Doesn't cost. Now the local vendors, most of the local vendors are manufacturing.
But just in case one doesn't have it in the OT, it does. You're not expecting it. They don't have it in the OT. Would you? Because I've seen Minu saying he doesn't use the cutter. He has got a Vanas scissors
Yes.
specifically.
So
for
initially, when we did not have this, we were using the Vanas only. If you are using the Vanas, make sure you use the new Vanas. That has not been used. You will be able to cut it, but the edge one, then the partial, that is where the partial one helps you. Full cutting, because the length of the Vanas will be very minimal. That is where you will have the problem.
Yeah.
You can do a partial and then remove it.
I think you can also use the scaffold technique if you're doing an IOL explant and an implant simultaneously. the scaffold technique of implanting the IOL which needs to go in goes behind the IOL which is explanted, and then once you move the explanted IOL into the anterior chamber, it gives you better control over your all your maneuvers as well.
Yeah, that's another one technique that has been widely. But why it so happened that after using so many mishaps we have had, we became so good in removing. I think all of you will, once you encounter such thing, you'll become good that you'll just do it as another procedure only. The other one is, I'm sure most of you, especially the beginners who have gone through this repeated iris touch during phaco, and believe me, once you touch the iris, it's going to be hell for you. Whatever you do, it is going to come behind you like anything. It will not leave you until you come out of the probe is shifted you. So this is actually a nasty thing to happen to any one of us. But the problem is it always happens most of the times. So what next? So this is, yeah, that's it. Once you go there, it keeps on coming. It keeps on. You want to go away from it, you just put in some aspiration, it keeps on coming. So that is that is what happens. Now, what are the causes? I think this is one important thing that we must know, because preventive is any day better. So when we know what is the reason, the first, because I train, I see a lot of youngsters doing. The first thing, the mistake they do is not respecting the central safe zone. The idea of the central safe zone for doing phaco is all your, apart from irrigation, whatever is aspiration or phaco, that has to be done, has to be in the central safe zone. If you don't respect the central safe zone, you are sure to go and catch the iris. And of course, there are all other pathological things like small people, eye face, and in the previous case, it was obviously about high fluidics and dynamics, or the sudden surge that can happen, then just catch hold of the iris. Now, how do you go about it? Immediately, first you reduce the fluidics, respect the central safe zone, make sure the aspiration port is away, whether it is the phaco or the IA, is away from the where the affected iris. Because that is only way you can prevent it to coming. Use the second instrument. Most of us manage using the second instrument to block that part and go ahead and do. And obviously, if nothing works, go in for a hook or a iris ring. So one by one, let us go through it. So once you get it, you have no choice, but you come back to this portion. No, I still have, this is small people where, and luckily for me, one side, the iris has prolapsed, so it's giving me some space. So I utilize that space, move the probe to the other side, utilize that space, turn the tip away, from the place and finish off the surgery. And that is one thing that we normally suggest. Utilize that whatever space is available away from the iris and go ahead and do. And using the second instrument to block here, once I've removed the, see, even if minimal also, now you rotate it the other side, you are able to do the IA. So remove the aspiration port away from the iris and keep aspirating.
Mate, would using a single iris hook?
Yeah, I'm coming to that. That is one of the options that is there. A second instrument, see, you aspirate, it comes, but you have to aspirate. There is some cortex there, you have to aspirate. Then what you do is, you take the one of the Sinski and just hold it there. Go below that, lift it up, go below, hold it, don't aspirate, turn this the other side and then aspirate. And that would be a better way of otherwise, the moment you hold it and you don't rotate it, keep the port there, it is going to catch hold of the iris, because the second instrument is only there to lift the iris and give you some space and hold it for some time. So it's important to hold it, rotate it to the other side, and then I'll just repeat it once more. So you lift it, tent it up slightly. It could be even for the phaco also, in case you are handling. Hold it, rotate this one here, and then you can aspirate it. And finally, this is not an just for demonstration purpose I have given is, whenever you have, that invariably it happens in the opposite side. Whenever you have, you can just use the iris hook there. Wherever the touches happen, you can use the iris hook and go ahead and finish up the phaco. That is the easiest and the best in case you don't want to have any more problems to injure the iris. That will be the ideal thing in case you are not able to manage. Thank you, Srini. Anything, any discussions?
Thank you, Mish. Any comments? Anything? Yeah. Prabhu? Yeah, wonderful. Now we have Dr. Vanati, and she'll be speaking on two topics. When if you get a wound burn, see the wound burn with all those newer phaco machines, the amount of energy used has come down, but with the use of something like Viscoat, which actually blocks that phaco tape, we are basically bothered about the energy that is used for the nucleus. We are not bothered with it, but wound burn is a very nasty thing to happen. So you have a patient with wound burn, what to do. Dr. Vanati will be speaking on that. And another important topic that she'll be speaking on will be what to do if you get a very hazy cornea on the first post-operative day. Vanti.
Thank you, Srini. So I think two very important post-operative conditions or two important complications, concerns which can occur, especially in people who are in their early phase of cataract surgery, is hazy corneas. One is post-operative and hazy cornea at the wound which can occur where you're operating here. No financial interest. So I'll first take you through hazy post-operative corneas, what can be next here. I think my subsequent speaker is going to be talking about inflammatory causes, so I'm not going to touch the inflammatory causes which are going to lead on to a hazy postoperative, but something which is very common is the Descemet's membrane detachment here. So postoperatively, how do you recognize it? You have a corneal edema or corneal haziness, which is not in proportion to the whatever events to an uneventful cataract surgery here. So that's when you would probably have a Descemet's membrane detachment top on your list to look at and see if that's what is causing a postoperative hazy cornea here. So important is to recognize those corneas which are at a risk for occurrence of intraoperative or Descemet's membrane detachments or Descemet's membranes which can detach and lead to hazy corneas postoperatively here. Commonly in old age patients here, they have Fuchs endothelial dystrophy, that's meaning a pre-existing poor endothelium, hard grade of cataracts here. And when you've landed up using an increased phaco power in these patients and uncooperative patients, these are the common scenarios which would lead to such a postoperative corneal haze here. When the haze is localized and limited, meaning your Descemet's detachments is shallower and it's only probably involving a particular part, commonly it involves near the wounds or near your stab incisions here, and you would be able to pick them up on your slit lamp evaluation here or have a high index of suspicion. It's good to take a mount for an anterior segment imaging with an ASOCT to look at the configuration of the Descemet's membrane detachment here, because recognizing the configuration, it's probably going to help you in a more successful management of your Descemet's membrane detachments. Shallow detachments localized to one particular point, not associated with any tears. They are planar detachments. They are not non-planar. They are not having scroll drop edges. Then it's very easy to settle them up, and some of them probably do just settle with conservative medical management here. But when you are having scrolled edges here, and when you are having regmatogenous detachments, or you're having a tractional detachments, I think this is more for completion of sake here. You have a significant amount of different types of classifications which can help you to categorize these detachments here. But one such which has evolved from India here and is highly quoted is the HELP algorithm, the height, extent, length, and the pupil-based algorithm, which could probably be a better guide to enhance your management of Descemet's membrane detachment in the postoperative phase. I think it's largely quite simple, and you really don't, I really do not refer to these. The simple dictum is you find it, wait for a couple of days here, and you find it's a more bullous detachment involving a larger area, threatening to involve your central cornea. Then you would probably go in and intervene as soon as possible here. Some of these are publications which do talk about the configuration or the associated scarring, especially in cases which you need to take on for endothelial keratoplasties here. So what you need to do when you're looking at conservative managements is you step up or you enhance your medical management in these cases here. When you would want a rapid visual recovery, then go in and bubble these cases. You can have simple pneumatic desmatopexies with air or with gas here, which provide a mechanical tamponade, and you can enhance it along using a transcorneal fixations here. Very large ones would need desmatotomies if there are tractional detachments here. So this is a short video here. You can see a very localized Descemet's membrane detachment, which is there in this particular case here. The rest of the cornea is looking relatively clear here, and these are scenarios where you would probably go at the opposite edge, 180 degrees opposite, and then bubble the Descemet's membrane and allow it to settle. If you do recognize it intraoperatively on the table, then it's much easier. Instead of leaving fluid to fill the anterior chamber, you could just leave air there. And again, a simple tip is not as this, don't allow a lot of fish egg appearance here. A single large bubble is more effective when you are trying to manage a Descemet's, doing an air injection into your anterior chamber for management of your cases in such cases. For gas, it's if you're having repeated detachments, you're having larger detachments, and you want your tamponade to be on for a longer period of time, especially in one-eyed patients, then you would probably go in and use your SF6 or C3F8 in these patients. But please do take caution that these patients should not be flying in their postoperative period here. It's a simple tip on how you would go about mixing your isoexpansile or non-expansile, 20% SF6 or 14% C3F8, and that really helps you, and you're sure that you're not going to have problems because of your gas bubbling in these patients here. And several times it's better done yourself to dilute rather than looking at your scrub nurse to take care of your dilutions, because improper dilutions can by themselves lead on to further problems in these cases here. This is when you're having a detachment, a scrolled edge, a large one. A simple bubble is not probably going to help in settling here, and that's when you're going to need your transcorneal fixations here to augment the settling of the Descemet's membrane in these cases. So once you've gone and bubbled in at an entry 180 degrees from the axis of the a Descemet's membrane detachment, a simple suture through and through involving the detached Descemet's will go a long way in settling up these cases here. And here you can see once you've bubbled it, you do have some amount of fluid which is collected in between the detached Descemet's and the stroma. That also needs to be released or needs to be stroked out for enhancing the or better settlement of the Descemet's membrane in such a case. So this is why yet another case of Descemet's membrane detachment, which has a scrolled edge or a detached edge at one corner where you can enhance using a transcorneal fixation. Last but not the least here, this is bullous detachments, which are a limbus to limbus, and they are particularly refractory to repeated bubbling in cases here. And this was one such patient who had come with the three bubblings done outside and not effective at all. So what we did found on an IOCT microscope is that there was a large fluid collection. I'll quickly run you through that video here. There's a large fluid collection in this patient here, and that required intrastromal vent incisions to release the fluid. That's the configuration of the bubble, of the detachment, a hazy cornea sitting there. So go in, bubble here, and you have an IOCT. You could see that you're in the right plane and you're not damaging and not going in the space between. You have to see you're going in the space between the Descemet's and the iris, and not between the Descemet's and the stroma here. And once you've bubbled, you go in and also put in intrastromal vent incisions to release the fluid in these cases. So you'll have to be again careful when you are releasing that you do not implant epithelial cells into your stromal vent incisions. Those themselves can have problems if you're going to introduce epithelial cells into your stromal vent incisions here. To enhancing further, especially in chronic bullous detachments by intrastromal vent incision is another maneuver in chronic detachments which need corneal clearing here. So the points to remember is to identify, either it's best done when you identify it on the table, and if you have identified early in your postoperative phase, then depending upon the configuration, and early intervention helps in rapid corneal clearing and the settling of the desmus membrane, avoiding the need for further procedures like endothelial keratoplasty here. So I'll just quickly go on in the interest of time, just a couple of slides on wound burns. I particularly have not faced much wound burns even during my learning phase here, but a word of caution is, when does it occur? When you've used high phaco powers here, excessive frictional movements the irrigation sleeve is either too tight or the amount of fluid irrigating your phaco tip is not adequate here. Obstruction by viscoelastic devices here, these could be the commonest causes here. How would you work on preventing them? Be careful about the amount of ultrasonic energy you're using to phacoemulsify your cataract, and learn to calibrate and tighter the energy depending upon the density of the cataract you're doing, with frequent fluid cooling of your phaco tips here. Modifications of your phaco tip devices are some tips which can help you manage or avoid a wound burn here. Once you had a wound burn, how would you go about managing them intraoperatively? Then forming the chamber becomes difficult here. You're going to have leaks here. So suture augmentation or suturing your wounds, radial sutures usually could land up with higher astigmatisms in these scenarios because of a scar induced. Horizontal mattress sutures work well in such scenarios here. Or secure the wound, you could use a BCL with a bandage with a glue application, and sometimes severe burns might need amniotic membrane grafting over the wound area as well here. Add on topical anti-glaucoma medications and antibiotics to keep your pressures low and also prevent infection in these cases. If the wound burn is very large, then you probably will have to resort to other tectonic procedures for reconstructing the surface at that particular region here. This is another picture which clearly shows, which has been augmented by sutures here, and which heals with a scarring here. An ASOCT can help you to look at the configuration. The particular complications which occur is delayed wound healing, sometimes fistula formations, recurrent leaks, iris prolapsed, astigmatism because of the scarring, and infection of the wound. I think I'll stop here, and thank you for your patient hearing.
Thank you, Anati. See, when you put air for the desmus membrane detachment, when do you actually take off the air?
Pardon?
You have done. You put in air to represent the desmus membrane. When do you take it off?
Normally, when I see a simple shallow detachment in the periphery, so it's a planar detachment. It is very shallow. It's not involving the pupillary plane. The rest of the cornea is clear. Then take them for medical management and wait. I normally wait just for 2 or 3 days here. And
No. After putting in air.
After air, when do you
release the air?
When do you release the air? So I normally do not for a desmus membrane detachment, and if they are smaller detachments, I do not do a complete air fill in these patients. So I do a 2/3 air fill and dilate your pupil a little here. So that is not going to cause a pupillary block glaucoma in your patients here. I would not want to go in and add a PI in these patients commonly here. So a 2/3 air fill, and anyway you are adding them, most of them you would put them on anti-glaucoma medications as well, along with the midriatic. So I don't go in and tap and release.
Yeah, I do, because I do a complete air fill. Okay. And I've had at least two cases of pupillary block, so I release them after maybe 2-3 hours. Otherwise,
you're particularly safe if you do a 2/3 fill here and you dilate, so that the inferior margin has you have a place where your aqueous is flowing through. Then you normally do not land up with a pupillary block.
Yeah, and one more thing, like I've seen videos where they are putting in air using a 26G needle. It doesn't really work. See, you already have aqueous inside. You want this to take the place of aqueous. So what ma'am has showed, uh, and she entered with the side port slit knife. So that gives the chance for the fluid to escape and the air to take its place. If it is 26G needle, it's sealed. Uh, then repeatedly you have to inject. Air won't go in. So then again you inject. So I mean, for me, I think it's better not to go in directly with a 2016 needle. Enter with and you make a partial entry with a keratome, then you can do it. It doesn't matter how much is going to be 1.5 millimeter. It doesn't matter, but you just have to make sure that you're doing it at the right place and not into the detached area to go opposite to where the DM detachment has happened, and then do it. So, Umesh, anything to add?
I think the wound burn thing nowadays phaco power most of the time because we are using modulated energies.
Yeah.
So that is most frequent is the blockage because of the visco.
Viscoat.
So first thing, the moment you think about that and just do that, I think you'll be safe.
It's also good to
And it
once you
occurs in
start-
just milliseconds. Once you don't have time also, so make sure that the blockage won't occur.
No, that is the reason why, like, you protect the endothelium with viscoat, then put whatever
Once
or
it's also
yeah.
good to the first 10 seconds you're just anterior to the nucleus
Remove
and
the
you do
visco
a
in the-
little aspiration and provide a space where you've taken out your ring and allow the blockage to go away, and then you go ahead and do
Yeah,
you
that one
usually
thing
safer.
definitely prevents wound burns. Yes.
In a phaco-fragmentation, generally we do not have a sleeve. So even if we are doing a small gauge fragmentation, unless we are doing through the ports, which are through the cannulas, there is bound to be, even with 23 and 25, we need to suture.
Thank you, Dr. Manthe. Thank you. Now we have Dr. Kaushik Murali, who is the president of Shanghai Foundation. Shanghai Foundation has got a huge lot of branches across India. He's in addition a pediatric ophthalmologist and anterior segment surgeon, and I request Dr. Kaushik to speak on see what would you do, what would you think of when you get severe postoperative inflammation on the first postoperative day. Kaushik, please.
Thank you so much, Srini. I would like to acknowledge my colleagues, Dr. Simran and Dr. Minija, who helped me with some parts of this presentation. So we are always scared, or it's our biggest nightmare, to have a severe post-op inflammation, and we are a training center. So invariably on a day we would see cases like this where you're completely confused and at a loss trying to understand what to do. So when you see this kind of an inflammation, first thing that happens is you panic. You panic because you're worried what your boss is going to tell you. You panic what the patient is going to tell you. And then there's such a huge pressure that we put on ourselves in terms of the expectations that we set to the patient, telling them that, oh, you're going to have crystal clear cornea, you can go home in 2 days, you can probably go play golf or go for a trip. So automatically that kind of puts that pressure on us and we go into a tizzy. It's good to just sit back, relax, identify what is happening, and then get on with it. So invariably the inflammation happens because of a break of the blood aqueous barrier, and most research shows that this would get resolved in about 2 to 4 weeks of time. There is pain, there is decreased vision, and there is anxiety both to the patient as well as to the doctor when this happens. Some of the risk factors have been long operative time, prior surgery, intraoperative complications, and when you've done extensive or combined procedures, you are more likely to end up with inflammation. That said, on the first day when you see it, it's good to go back to the history to identify what has happened. So in a uveitic cataract, invariably you will see inflammation. So that is a given. So there is no point in you panicking if there already was a history of uveitis and then you've operated on that patient. So that is bound to happen. You would expect that the inflammation was controlled preoperatively. With new IOLs, we don't see too much of an issue, and there is a good postoperative outcome. However, in these patients, if it's a mild kind of an inflammation where you see grade 2, grade 3 cells, just prednisolone acetate 6 to 8 times a day that is tapered works well. You may have to put them on these drops a little longer. Where you see a fibrin membrane formation or something like a hypopion, giving a subconjunctival midricaine works. And again, you may need to increase the dose of steroids as a loading dose. Topical cycloplegics always help in terms of reducing inflammation. You could look at atropine eye drops wherever you think it is severe. More severe, oral steroids, 1 milligram per kg body weight has to be started. This is just a short video showing how the midricaine is kind of mixed and how do you inject it in. Again, typically most midricaine is made of a combination of 0.2 ml of lignocaine, 0.1 ml of atropine and 0.2 ml of adrenaline. Uh, Rarely also you can mix in dexamethasone. Again, that is given at about 4 milligrams. You anesthetize the inferior fornical area. You could put a plug there, ask the patient to look up, and you could inject it. You could do it under naked eye. You could do it on the slit lamp too. Making the patient lie down is more sensible way of doing it. There are reports of even atrial fibrillation happening after injection midricaine is given. So don't take this particular step very lightly. The second part of it is to go back and look at the OT notes, assuming that you're not the surgeon and somebody else has done it. You would see probably some residual cortex that is triggering it, some leftover viscoelastic that is causing this. The question then comes saying that, what do you do? So when do you go and re-intervene? With every re-intervention, there is a possibility of other complications happening. So when you see a residual cortex that is probably in the visual axis and not going away, or a significantly large amount of chunk, it may need a aspiration. Otherwise, conservatively managing it would allow this to be resolved over a point of time. What scares us more is seeing a cornea like this, where you see it anywhere between 12 to 48 hours. Typically, this is because of toxic substances entering the anterior chamber that causes a sterile, non-infectious kind of a response. Here, you would see decreased visual acuity. You see a limbus to limbus corneal edema. There is a raised intraocular pressure. You could see a hypopyon. Fibrin could be there. You see an irregular pupil, and patient will have mild pain and redness. The question then comes saying that where did it come from? Typically, it can come from 4 different areas. It can come from the surgical instruments because you've not you've left over some enzymes, detergents that have not been removed out. Endotoxin contamination can happen after sterilization. Intraoperative fluids, intraoperative consumables like your viscoelastic have been contributed. Very rarely postoperative medications can also cause, but that's not so common. Some kind of a very simple kind of a flow chart is share information with other colleagues, find out if this is an isolated attack. If there are 3 or 4 who are having it, then probably there's a common source. Look for any recent changes that have happened to the consumables, and then you start looking at it. Microbial study, again, in the first day seeing such an inflammation, unlikely to be an endophthalmitis, unless it's a very fulminating kind of a picture where you're suspecting something like a Pseudomonas infection. But otherwise, it happens. Unfortunately, we don't have any registry per se for TAS, so information that gets shared is very little. But go back to your alumni group, share it with if there is a local city group, talk to colleagues and find out whether TAS is happening. So again, the question comes, very severe inflammation, TAS or end off? Well, as I mentioned, first day seeing endophthalmitis is not so common. Where you have a high suspicion, you could look at investigating it, proving that it is endophthalmitis, and then taking it up. Usually, intense topical steroids works. Try and understand what has gone wrong to prevent a larger cluster from having an outbreak. Look at the patients, look at the drops that you've used, look at the consumables. If you're suspecting an end off, if you're suspecting it, look at the surgical environment. You may need to get cultures from different sources. Look at if you have a HEPA filter, look at it. Sometimes they're not bolted in, and that can create some kind of a scaffold. So if you're worried about an infection happening, it's a good idea to look at it. Again, go back to the basics. TAS, if your consumables are clean, you've washed your instruments before use, your surgical steps, you've done an adequate wash, you've removed whatever is in the eye that need not be there in the long run, invariably you're going to get away with it. So inflammation is part of the game. You can't wish it away if you're doing surgeries, but it's important to remain calm and understand where you could have gone wrong and tackle it in a very graded kind of a manner. So thank you.
Thank you, Kaushikal. We'll have the discussion at the end of talk by Dr. Gopal, and he'll be speaking on extremely disturbing postoperative floaters. We have all had patients complaining of floaters, and on suboptimal visual recovery in a clean postoperative case. What next? So, Dr. Gopal Pillai.
Is the mic on? Yeah.
Yeah.
So first on, we will talk about troublesome floaters. Cataract surgery is no longer a rehabilitative procedure. It's a refractive procedure in which nothing short of 6/5 is acceptable. So there's a very high patient expectations, and vitreous floaters caused by degenerative or pathologic alterations in the vitreous is perceived as flying objects around the eye, and they are very disturbing. So symptomatic visual floaters, they don't actually alter the visual acuity. Visual acuity may be 6/6 or 6/5, but these things will be floating around, and it is a very, very common cause for patient dissatisfaction. There's no very well defined consensus of management. One may be that it's a pre existing floater, and a pre existing floater in the presence of a cataract, which actually dims everything, would be not so visible preoperatively. But once the cataract surgery is done, and now the patient's vision is very clear, these floaters becomes visible and more disturbing. Secondary floaters are intraoperative by leakage of lens matter or OVD or air bubble, or if there is a PC rent or some problem like that, or a postoperative PVD, or a degenerative vitreous syndrome, or even a retinal break or tear can also cause it. So these are the different causes. Some personality traits like type A personality perceives these floaters. Generally, all of us, what we would say is, okay, this is nothing, this would just go away, you just ignore it, it will go away. But these type A personalities find it very disturbing, and they would not tolerate such a floater. So high dissatisfaction is there. And obviously, yes, there will be some scattering of lace which causes contrast sensitivity to be diminished in these people. And strong positive correlation is detected between quality of life and a qualitative ultrasonography to actually look at quantitative ultrasonography to look at floaters. So ultrasound scan detects these floaters, but we know that a PVD in an older age can produce some of these vitreous floaters, and many of them don't complain of floaters. So OCT can also image floaters. SLO, both the umbra and the penumbra caused by the vitreous opacities can be visualized. You can see this is an ultrasound on the left, which you can pick up the floaters, and you can see that in the OCT also some darker areas may be seen. The darkest are the umbras, and the surrounding grayish halo is the penumbra. So history taking, basically this patient may have a retinal detachment, prematurity, or arthritis, or midline defects or something like that. A complicated cataract surgery with a postoperative notes or intraoperative notes may be there. And a fundoscopic examination should basically target and exclude inflammation, because vitritis is a first sign of endophthalmitis and pars planitis or something like that. So rule out inflammation, which is actually a reversible cause of floaters. And then if it is something like asteroid hyalosis or vitreous hemorrhage PVD, so depending upon the type of floaters, you can decide whether it is a reversible or non-reversible, and look for any peripheral breaks. So quality of life, definitely you can ask. And clinically significant persistent floaters, you can either observe, or conservative management, you can give some placebo drops, or you can consider intervention. So choices of intervention would be, one is phlotrectomy, which we don't advocate, but there are certain patients who are very persistent, very large floaters, in which we can definitely offer that. And Nd:YAG vitriolysis is the other option which is there, acts only on the collagen component, you can do that. So phlotrectomy by MIVS, definitely there's those patients whom I have done, they have significant improvement in their visual acuity. Even though the vision was 6/6 preoperatively and postoperatively, the quality of vision improvement is significant. Nd:YAG vitriolysis I have not done, so I think it may be a little more because we are the control on the vitreous is a little less, and I feel it may aggravate certain problems later on also. Pharmacological vitriolysis is another thing, hyaluronidase or vitrease, or the newer drug which is coming in, urea, all those things which can be there, but not approved for symptomatic visual floaters. Then International Survey of European Vitreoretinal Society floaters, they published articles, retrospective survey, overall satisfaction about 476 out of 581 patients, lower presenting with smaller opacities. And that is safer when core vitrectomy and cut rates were done. No significant advantage for more than 4,000. So in conclusions, there is no single consensus. You need to personalize, and proper case selection is important if you want to do phlotrectomy, and identify the well-suited cases. and risk-benefit ratio, because if there are a lot of lattices, if there is a history of retinal detachment, it is better that we wait. If there is nothing like that, if it is an old patient, already PVD is there, it is a easy surgery. Thank you very much. Should we go to the next presentation? Are we short of time?
No, no, no. Just rush through the presentation.
Yeah. So the second talk would be a suboptimal visual recovery after a clean case which is seen post operatively. So we should basically look at, in this talk, we will look at what are the reasons. That's the only thing we need to find out the reason. And we should find out what can be done now. And then more important than that also is how to counsel the patient and documentation, because these are problem cases. As I said in the beginning, cataract is no longer rehabilitative. It is a refractive procedure which requires 6 bifusion, and nothing less than that is acceptable. So preoperative evaluation, we will always look at, is the cataract commensurate with the visual loss? But sometimes when it is a white mature cataract with very poor vision like hand movements or PL, you have to rely on the pupillary reflex if it is good. Or so pupillary reflex before dilating the patient is a very, very important measure, and it gives you a very simple evaluation of the overall visual potential of that patient. Now, if the retina was visible, is the retina, optic nerve, the vitreous, everything, is it normal? Are there any floaters like we said in the last case? Are there any preoperative history of any stroke or something which can actually jeopardize, or CNS problems which can jeopardize the vision once we do the cataract surgery? That's very important. Now, preoperative pathologies are often there, like high astigmatism, which definitely all the cataract surgeons would definitely look up, because an IOL power calculation would be done. Glaucoma, maybe it was missed preoperatively, but glaucoma can cause obviously a lot of damage. Floaters, during cataract, through cataract, we may not be able to assess a lot of floaters sometimes, and that is sometimes missed. Macular and retinal pathology. So macular hole, diabetic macular edema, AMD, any scar, any choroiditis, any problem that can occur in the macular hole, any problem that can occur in the VMT, mild VMT, which can actually progress after cataract surgery. All these macular and retinal pathologies can be there. Optic nerve pathologies, including optic neuritis, optic atrophy, any of those can be there, as well as stroke. Intraoperatively, a block perforation. Nobody knows. I mean, if you inject xylocaine into the vitreous, definitely yes, the cornea is going to be steamy. But if you perforate and you go inside, a double perforation, and inject, the block would be perfect and you would do a cataract surgery, but final end result may be a retinal hemorrhage or vitreous hemorrhage or something like that. IOL decentrations can occur intraoperatively, but that would not be a clean case, I would say. Intraoperative AION, when the bottle heights are very high and the pressure inside the eye is quite high, and you're working on a very closed cavity, sometimes in labile optic nerves like a glaucomatous optic nerve or a diabetic person, you can have an intraoperative AION. Also occurs when you are applying significant massage after a block. Now, intraoperative vascular block, we should know that the perfusion pressure of the retinal vein is somewhere around 20-25 millimeters of mercury. And if your pressure intraoperatively goes up to 30 or 40 because of the high bottle height, and sometime when you are not aspirating enough, the pressure increases, something like that, then you can end up in a vascular block. Intraoperative choroidal detachment, suprachoroidal hemorrhage in a mild way, you may not consider. I mean, sometimes it's just a little harder eye which you manage, just like we discussed in the beginning. Vitreous hemorrhage intraoperatively can occur because of any other reasons as well. Postoperatively, you can have a choroidal detachment or a delayed suprachoroidal hemorrhage during the first 24 hours, and day one, the anterior segment may look normal, but would be a suboptimal visual recovery because of these problems. High IOP, yes, there can be corneal edema in high IOPs. Sometimes what can happen is high IOPs can cause functional optic nerve damage and can present with a suboptimal visual acuity. Similar in malignant glaucoma, but that would not be a clean case. Early endophthalmitis where anterior segment is reasonably clean, but vitritis is there, the patient may complain, and that is something that we have to look at. Vascular block and AION are two other postoperative problems. I am skipping the delayed postoperative because we are basically concerned about day one when we are looking at this thing. What can be done now? Like if there is an astigmatism, you would intraoperatively also probably do a lot of procedures to alleviate the astigmatism, maybe a toric IOL, maybe incision planning, maybe keratotomies, something like that. And glaucoma, preoperatively, many of these glaucomas, whatever damages occur to the optic nerve is permanent and cannot be reversed. But maybe you could do things to control the IOP. You may not use steroids and stuff like that. Floaters, we had one talk on that, so I am not repeating that. Retinal pathologies, it depends on the retinal pathology. Maybe it's a diabetic macular edema or an RVO, or with macular edema or an AMD, you may consider injections. If it is a VMT or a macular hole or something like that, you may require a vitrectomy. Optic nerve diseases, if it is a pit, there are some reversible optic nerve diseases like optic neuritis or optic disc pit with fluid sensor neural detachment. Those are manageable, but generally optic nerve diseases with atrophy, you cannot do much about it. Block perforations, if you have a suboptimal visual acuity, you look at the retina and you see perforations, you must immediately laser those areas. And depending upon the amount of vitreous hemorrhage, you may consider whether we have to conservatively manage it or do that. Intraoperatively wrong powered IOL, that is a problem. You may have to change the IOL. IOL decentrations or dislocations in the first 24 hours, but that would not be a clean case. When you see in the first posteriority, you would be seeing that. Probably you will have to redo the surgery, or maybe you will have to do a vitrectomy, remove the IOL and put in another IOL. Intra-op AION and vascular block and all, you have to treat according to the usual consensus. AION is generally intraoperatively, maybe you can give some IV methylprednisolone to see whether it is improving. It is a little different from the non-arteritic AION. And choroidal detachment and suprachoroidal hemorrhage. Choroidal detachment, if it is due to wound leak or something like that, basically you have to plug it. Suprachoroidal hemorrhage depends upon the amount of suprachoroidal hemorrhage. If it is mild, you may observe with a reduction of pressure and it may subside. Vitreous hemorrhage also depends upon the amount of vitreous hemorrhage which is there, and we will manage it accordingly. Now, post-op choroidal detachment and suprachoroidal hemorrhage, it's almost equal. I mean, depends upon the amount of that. And high IOP definitely should be managed. Endophthalmitis, vascular block, any other retinal pathology which is developed. I mean, whatever we talked about in intra-op pathology, we have to basically do. Vascular block has to be treated that way. Any other retinal pathology, look whether this is going to be reversible or not, and then plan. Now, counseling of the patient is quite important. Missing a pre-op pathology is a mistake. So you have to basically tell the patient that the cataract was dense and we could not exactly see the pathology, something like that you have to basically say. Intraoperative complication, we have to be rather honest, and we have to say that only in this tiny minuscule percentage of patients this occurs, and unfortunately it has occurred in you, and we will do whatever it is possible to manage it. Post-op pathologies, definitely you can always say, textbook says this is the percentage. Even intra-op and post-op complications and pathologies, we can basically look at it. End of the counseling has to be very, very nice, otherwise the patient will land up with a lot of problem, a court case and all those things. So we talked that it is you have to tell the patient about infection, but at the same time you have to talk to the patient positively about how you're going to treat the patient and possibility of vision recovery, etc. Breaking news slowly, firm yet soft and empathetic. And financial transactions is very important. Sometimes what happens, if there is a problem, the doctor gives the money back to the patient. And that can lead to some problems, especially in the court legal side, that, because you had a guilt of a mistake, you gave the patient money back. So all those problems are there. I would not go deep into it. Documentation, all these cases are potential legal cases. It will end up in a legal tangle. So each document preoperative and postoperative vision and reasons for visual loss found and documented. And document that you have explained about this to the patient, and you have explained all possible management options and the prognosis. And all this has to be well documented. And if you say that these are the problems, we found out the problems, we have counseled the patients of the problems, we told the patient how we are going to manage it, and then if he has not gone through that, it is not our problem. Thank you very much. To conclude, we have to have a robust pre-op evaluation, all efforts to prevent intraoperative problem, vigilant and high index of suspicion for any early post-op pathology. Be available. The senior surgeon has to be available for counseling if there is a problem patient, and good documentation, and refer wisely. Even a second opinion can help. because the peers will talk about the same thing. All patients, when there is a problem, they will develop a small mistrust, especially if the doctor is a little junior, there will be a mistrust. And be honest with the patient. Thank you very much.
Thank you, Gopal. We are almost through. Umesh is a wonderful communicator. Yeah, it's basically what I want to say is everything is okay. Everything is okay. The IOL power, everything is okay. And when you don't have any pathology seen there. So the patient has a subtopic, whatever from the normal examination that you have. So what do you do in this case?
Yeah, I think the newer diagnostic equipment will come to your help. For those who don't have, but you can refer it to people who have eye trace. Eye trace actually now measures the corneal wavefront, the lens wavefront, and it equally identifies where the exact problem is. Where we are not able to identify, it identifies. Probably from that standpoint, we can take a call. Apart from that, literally we have not seen, it could be one of the causes where we can identify definitely. What I would add to what Dr. Gopal has said is have a robust consent form in place, and most of the consent forms, with the newer consent forms that we have all the possible implications here, and that should save your skin.
Thank you all. I think we have overshot time a bit, and thank you all for staying back for this last session of AIOC 2023. I hope you all had a wonderful time in Kochi. So thank you.
Thank
You
you
for your
thank
support.
you all.
Thank you.